Welcome to Casual Conversations. I'm so excited to have you all here again for another show. And I would like to jump right in and welcome Dr. Wexler back to the show.
Thank you so much. I am so pleased to be back. I so enjoyed getting to meet some of the folks who are here again today and to answer lots of questions last time. So I hope we can get to more today.
Absolutely. And I think this topic is so important. I felt it was important to have you back on the show. For people that didn't get to see you in October, that episode is up on YouTube.
Thank you. My name is Tamara Wexler. I'm a neuroendocrinologist, an endocrinologist who focuses on a specific set of hormones: stress hormone, sex hormone, thyroid hormones, growth hormone, and others. I have had a career in both clinical work and research, a little bit of time in business as well, but a focus throughout on education, educating patients, educating colleagues, educating the public. That's really my passion. And my focus since about 2015 has been the pituitary hormone changes that can happen after concussions or traumatic brain injury.
Is this something that goes back within the context of brain injury being a new field compared to others?
For growing awareness, probably started in the past few decades. The first set of guidelines probably came out in the last 2 decades, so that part's fairly new. And happily, awareness has been growing and knowledge has been growing.
And it is just so important to ask changes in men versus women.
That's a great question. So actually, there's not been a lot of focus specifically on women or on the differences between women and men. It comes up just because you measure different hormones in women's and men, and that has been described in the literature. But there's a lot, I think, that's left to be studied in women and in men. But in women specifically, one of my concerns is that sometimes women or girls who may have the exact same condition, hormone deficiencies after a concussion or another type of brain injury, the symptoms they're describing may be assumed to be due to something else, and someone may not know to look for it: irregular periods, changes in mood, or fatigue. And so I think it's a particular concern. There's also other things to study in the field of concussions in women. How did the concussions happen? Are they more prone to them based on either differences in physique or different sports that women may play versus men? There's a lot outside my field that also is being studied and needs further study, but within the connection with hormones, absolutely. I think there's not sufficient focus on the role that estrogen plays in symptoms, for example.
If the average woman went to her primary doctor with these symptoms, what would the doctor say?
I hear all sorts of things from patients. It's just the way things are. They might get better over time. There's not a lot to be done. And it doesn't feel good not to feel heard or to have your symptoms validated.
Shall we switch to the slide deck?
Great. And I am going to ask everybody, please chime in with questions. So we'll focus here on the changes that can happen after concussion in terms of pituitary hormones. I'll talk about what those are and when it makes sense to think about the evaluation and then replacement of them. I like to start with the same case, I will say. Let me go back one. Okay. My interest in this entire area began with a patient. So I'd studied pituitary hormones for a long time, both excess hormones and deficient hormones. And top of list for the potential reasons for hormones had always been traumatic brain injury. But I honestly myself wasn't that aware of it, hadn't been really taught about it as much. I was familiar with it, but I started thinking about after a patient was sent to see me. And he was married, had kids, had been an avid cyclist until he had a bicycling accident, and had been an investment banker until the accident had to stop because of the symptoms. And I saw him about 6 months after his injury, and he was describing cognitive, emotional, and physical changes that had occurred. He had trouble with thinking and coordinating his thinking in a way that was different than before. He termed it brain fog. That's pretty common. Was having a depression. He didn't really have get joy out of any of the things that he used to before. He felt inadequate as a provider and a parent. He gained 20 pounds over 6 months. That had been particularly notable to him because he'd been very fit previously and in fact remained within a normal BMI. It's a term we use to describe weight for height. And he'd lost his libido, was experiencing erectile dysfunction. It was for those reasons that he had been sent to me. He had also previously seen someone else who had put him on testosterone, but he hadn't had any improvement in his symptoms and he'd stopped it. But this sounded to me like more than potentially just testosterone. A little bit more history on this particular patient. Before I met him, 3 months after the injury, he had had an evaluation of hormones we will talk about in probably about 5 minutes. Cortisol is the stress hormone. It's essential for supporting the body during times of stress. Too low is bad, too much is bad. You want to measure it usually around 8 in the morning. So this was measured a little bit late, but it didn't look abnormal. TSH is one of the measures for thyroid function, and we'll talk about that in a little bit. That looked normal. The testosterone had looked low when measured at 10 a.m., but when measured at the more appropriate time of 8 a.m. was normal. And IGF-1, which is a measure for growth hormone, looked normal. So with everything essentially looking normal in what I saw when he came in, is there any reason to think that he might have pituitary deficiencies? And if he did, would it have anything to do with his symptoms? And that's what we're going to unravel a little bit today. If you recall, he had said that he was in a dark hole and that he was in a brain fog. And I lifted the first piece from a letter he sent me, and I find it instructive. So I'm going to read a little bit from the fuller context. He said, "Right now, I'm in a dark hole, and all the ropes that have been thrown down to me, none of them have helped me. I'm looking for another rope." And this, to me, this really underscores the dramatic change a lot of these patients can experience, a lot of people can experience after a concussion. Many people have tried lots of things and just aren't feeling themselves. I think it's particularly important to know that there may be something that can help, but to be very careful not to set expectations too high. So I tell every patient that comes in that it is true that pituitary deficiencies are seen at higher rates in patients who suffered traumatic brain injury, including mild concussion. Not all the symptoms are necessarily due to pituitary deficiencies. There's a lot of overlap in symptoms. But that said, if a symptom is due to a pituitary hormone deficiency, replacing that deficiency should ameliorate or even reverse that piece of the symptom. So you can have symptoms and deficiencies, but you won't really know if the symptoms are from the deficiencies until you try to replace it. I use the image of Edvard Munch's The Scream because the inspiration behind this painting is when Munch said, "I sensed a scream passing through nature." And what this patient wrote to me really reminded me of that. So the goal here in thinking about pituitary hormone deficiencies is to think about whether there's something that is missing, that the replacement of which would help a patient both with their symptoms and with other recovery. There are things they won't feel that would be healthier if they had a full hormone. I'm going to start by talking a little bit about what we know, the evidence for pituitary deficiencies after traumatic brain injury, and then we'll talk about the pituitary and come back to the clinical implications.
I just want to acknowledge that his lack of libido, and I mostly speak with women, but the importance of one's sex life and connection, all of those things are so important. And I think that's a place in brain injury that certainly hasn't, really been in addressed, especially with women. And I think the loss of that really echoes through relationships. I did want to acknowledge that was one of the things that he had come to you with.
Yeah, it's interesting. Decrease or loss of libido can come from many different things. Hormone is a small piece of that. Depression for another reason, any other sort of physical changes can also lead to that, but it certainly can be hormonal. What I find interesting in part is that it's always been assumed to be part of the sex hormone axis, estrogen or testosterone, specifically testosterone, in fact. And I have seen cases in which symptoms that you would expect to be due to testosterone deficiency aren't. There's not a testosterone deficiency, but there are other deficiencies such as growth hormone deficiency. I talk about it in a little bit. There's a really interesting paper done. The last name of the first author is Cuesta. It was published in 2016. And he looked at people who had a history of TBI and were describing essentially, for men, they were describing loss of libido and erectile dysfunction. For women, they were describing irregular periods. And yes, there was a higher incidence of sex hormone deficiencies, but there was also a higher incidence of growth hormone deficiency and other pituitary deficiencies. So that plays into this case. And I think you're right. It's really important to think about. I fear sometimes that some patients aren't highlighting that enough in terms of why they aren't feeling like themselves. The pituitary deficiency, what we know is that they are seen at higher rates in adults and in children who've suffered concussions. Reports in the literature range in the chronic period, meaning at least 3 months out after the injury, anywhere from 15 to 62% in adults. If you try to standardize the way they're measuring the population they're looking at, comes in around 25 to 30% of patients who for some reason are being tested for it. So it's not to say that 25% of every single person who ever has a concussion, but the population studied in these trials, the median is around 25 or 30%. And we'll talk a little bit about why there's such a broad range there. I do want to mention, I'm specifically talking about the chronic period after injury. So in the first few months after a concussion or a more severe traumatic brain injury, there will be lots of shifts in hormones. And many of them we think might be functional, meaning that it's helping the body to focus on what it needs to, and they may not have any meaning for later on. When we talk about the cortisol axis, which I've mentioned a little bit already, that one you do want to worry about in the acute period, but even changes there in the acute period don't predict changes later. So we're really talking about two different periods, the first 3 months after an injury, and then what happens 3 months and later out. So we're focusing here, and I'll take questions on the acute period, but here we're focusing on 3 months and later out. These pituitary deficiencies can recover over time. If you look at 3 months and 12 months, sometimes you have a deficiency at 3 months and it's not there at 12 months, or they can show up later. So you can have no deficiency at 3 months and things show up at 12 months, or they can be static. You can have a deficiency that becomes chronic. Thinking about the different pituitary hormones, as you look further out after the injury, growth hormone or the sex hormone systems appear those that are most often affected. And this varies a little bit time after injury, with growth hormone being predominant as you look further and further out. One of the reasons you have such a broad range, I said 15 to 62% in adults, children have a similarly broad range, is that the studies use different diagnostic tests and thresholds. There are guidelines as to which tests and thresholds should be used. So the variance in the literature is a little bit hard to explain, but suffice it to say, that's one of the reasons for the broad range. And when you come to trying to think about, should I evaluate this in an individual, there are very clear guidelines. It's really hard to predict who's going to develop pituitary dysfunction. The best we have are symptoms. There has certainly been lots of interest in looking for other predictive characteristics. Okay, so because again, so many people have concussions, how do you know when you should think of pituitary deficiency playing a role? People have looked at injury severity, and we know that deficiencies can develop after mild concussions or severe TBI. So on an individual basis, it's not helpful to try and separate it out by the type of injury or the severity of injury.
And let's jump in for 1 second. So that would be mild TBI concussion or sports related concussion, to moderate TBI, all the way to severe, and severe where you have someone in an ICU. So it's a whole range. So what you're saying is that there isn't, for this type of injury, it's going to happen, and for this level of injury, it's not. So that is not a predictor.
Yes, that's well put. So early on, it was thought that, okay, you should look for this if somebody ended up in a neuro ICU or was hospitalized overnight right after the injury. And it's clear that that's not the case. You can look for it then, but that's not sufficient, and you're missing a lot of people. You mentioned recurrent sports injuries. I'll say that there's also been some interest in looking at whether the type of injury makes a difference, and it doesn't. I should say, we don't know that it does. It hasn't been as well studied in every group, but the information that we do have suggests that this can occur at a higher rate in different types of injuries, including recurrent sports injury. Those are largely case reports. So adolescents who've had boxing or kickboxing injuries, or adults with, those are the first sets of cases that were described. That's why I have there's a bronze for those who can't see the screen. It's in the Smithsonian American Art Museum of someone who's just been hit in the head. There was a very nice, well-designed study done by Kelly and colleagues published in 2014, and he was looking at retired NFL football players, so professional sports, and he looked at growth hormone deficiency and found that in those retired NFL players who self-reported on the field and who self-reported a poor quality of life, 41% had growth hormone deficiency. They went back later and looked at this again because there's some evidence that BMI, so people's weight, essentially, are they obese, are they underweight, are they normal weight, affects how you should interpret growth hormone results. And even using that much more strict categorization, which hasn't really made it fully into the guidelines, about half of this number, 19-20%, still had that growth hormone deficiency. A large percentage of people who, again, were reporting poor quality of life. There have been more studies now in the military population. There were 2 large studies in blast injury, and then there's a third recent study that came out in 2020 that was non-blast injury. And I'll just say that basically across the board, they show that there is a higher rate of pituitary problems in patients who have experienced TBI. There was one looking at blast versus non-blast, and they found more frequent in blast, but those that have looked in non-blast have also found that there is a higher rate for people who experience a concussion at some point during their deployment.
I'd also just like to jump in there. It would be very interesting in studying in people with a history of domestic violence, IPV, where you have multiple injuries, to see if that population would be another group to screen for.
I am so glad that you mentioned that. I think that there is insufficient conversation about that in all forms. And certainly, again, any type of concussion, head injury, we believe predisposes to pituitary deficiency in the chronic period. The symptoms that are experienced may be compounded by other things that can happen during in the course of a relationship that involves domestic violence, in the course of deployment where there may be trauma. So the post-traumatic issues can pile onto that, and in a way that is, I think, will be interesting to learn more about, what we don't know a lot about. But I think it is always very important to think in a patient who is describing persistent symptoms for any reason, has any type of history, head injury, domestic violence, recurrent sports injuries, hit their head on the top of the car and felt weird after in a small car accident, anything. It's important to think about this, because if you do find a deficiency, you have the opportunity to potentially be able to help.
And I think that's what's the most exciting thing about this, is that you're missing this, you add this, and it should help the symptoms. There's very few avenues in brain injury that have that option.
I never know how, I get very excited about that, but I also want to be careful to say it's hard to know how much it will make a difference in everything. I think most people understand that, but it's so hard not to want to find something that will fix it all. And you really can reverse symptoms due to the deficiencies themselves. Coming back a little bit to the attempts to look for predictive characteristics, so that you're not just doing a full screen on every single person who's ever had a concussion of any type. There's also been attempts to look at imaging, CT, MRI, other types of imaging, and there's no real clear correlation between the characteristics and knowing that someone will have a pituitary deficiency. I get asked about this a lot. They didn't get an MRI, or they didn't look at that pituitary. It doesn't really matter. To generalize, it doesn't really matter, because that's not going to predict if somebody has a deficiency or not based on what we know. Looking for biomarkers, there's a lot of interest in this. There was some reports about 9 years ago now that you had higher rates of antibodies to the pituitary and to what signals the pituitary, which is the hypothalamus in the brain, but it was still only around 50%. I have the 60 and 48% to be specific for anti-hypothalamic and anti-pituitary antibodies when studied 5 years after the injury. But that's still not clinically particularly useful, because if somebody doesn't have it, it doesn't tell you they won't have the deficiency. It's interesting to think about it in terms of potential pathophysiology and why patients get this, that they're developing antibodies. But again, if you have someone in front of you and you're trying to decide whether it's worth an evaluation, the best we have is symptoms. I talked a little bit, because you asked that, you made that great comment about libido, Katherine, about symptoms of hypogonadism, low levels of sex hormones, hypogonadism, and they do predict some type of pituitary dysfunction. not necessarily hypogonadism, but some type of pituitary dysfunction. So irregular periods, low libido, lack of spontaneous morning erections in men is much more specific than just erectile dysfunction. And it's important to consider that a clue that there is potentially a pituitary issue going on. I'm happy to answer more questions about what we know about the phenomenon of post-TBI pituitary deficiencies now or later, but if I don't see highlight if there's a question. Otherwise, I'm going to talk about the pituitary itself and why it matters. We know that pituitary deficiencies for any reason impact health and quality of life. So remember, physical effects, there are emotional effects, there are cognitive effects. And if they're not diagnosed and treated, they're associated as a whole with increased mortality as well as morbidity. So it's an important thing to think about so that you can diagnose them and then follow guidelines for replacement. I list here some of the symptoms, and I deliberately listed symptoms that can often be thought to be vague or non-specific. And that's true. There can be vague and non-specific symptoms. There's a high degree of overlap between symptoms that you can get from pituitary deficiencies and symptoms that you can get from other things having to do with a traumatic brain injury. So there's not any one particular symptom that makes you think this is definitely it. You have to go ahead and test, but they can increase I'm going to list out here the anterior pituitary hormone. So I specify your anterior because the pituitary also has a posterior piece to it that is not thought to be as relevant in the chronic period. I know that this isn't going to be visible to everybody. Katherine, should I describe what I'm looking at or just go ahead and point out where the pituitary is for those who can see?
Yeah, no, why don't you, describe as best.
Sure. So what I have up here is a coronal image of an MRI of the brain. All of this gray area is brain tissue. Where it's a little bit darker, that's fluid. And there's this bright signal here. It looks almost like a rectangle lying horizontally, but with a little stem coming up from it. That's the pituitary infundibulum, or the stem that hangs down, and the pituitary hangs from that. That lighter bar at the top is the optic chiasm, and this is the size of basically a normal pituitary. It's a little bit more helpful maybe to think about it where it is in your own head. Please, nobody should ever try this ever at home, but if you chose to have a chopstick or a testing swab up your nose and kept going through the cribriform plate, through the bony plate, you would run into the pituitary. So that's where it is. It's the intersection of basically, if you point at the top of your nose and at your temples, it sits right there. And the hormones that it makes include growth hormone. Growth hormone goes on to lead to the production of IGF-1 in the liver. We talked about that as an original thought to be marker for growth hormone. It's helpful if it's too high, for example. LH, or luteinizing hormone, and FSH, follicle stimulating hormone, are the hormones that lead to the production of estradiol in women in ovulation and lead to testosterone and sperm in men. TSH stands for thyroid stimulating hormone. So every time you see a TSH on your annual blood screen, that's what it is. It's the thyroid stimulating hormone. It tells the thyroid gland to make thyroid hormone. And ACTH is the signal for cortisol, stress hormone. I list prolactin separately on the screen that we're looking at because all of these other hormones are stimulated to be made and secreted by the pituitary. Prolactin is tonically inhibited by signals from above. So any interruption to the area, you could actually get an increase in prolactin. You've released the inhibition.
And these occur in men and women, but different levels are normal within that range of the sex organs you were born with.
Yes. So you can expect different levels if for what your body itself would be making. If anyone was born with ovaries would have more estrogens. People born with testes without ovaries would have more testosterone. Women also have androgens. Men also make estrogens, but the level is very different. Both make prolactin. It's not just sex or gender, but also age that determine what we believe to be a normal range. The order I just went through them is important. So growth hormone, LH and FSH are the sort of sex hormone signals, TSH, thyroid hormone, and ACTH, the cortisol signal. That's important. It is the order at which classically it's thought that you're more likely to have a deficiency, but you see also all sorts of combinations in practice. It's also the reverse order that you need to replace them in. If people are deficient in everything, you must replace cortisol first before you go on to replace thyroid hormone, or you could precipitate an adrenal crisis. Then you think about the sex hormones, and then you think about growth hormones. So the reverse order is the stepwise order for replacement. And I'll talk about that in a little bit more. We talked about the normal range. Normal can be misleading here. And I like to use thyroid hormone as an example. So in an intact system, your hypothalamus and pituitary send a signal to the thyroid gland. I focus on the pituitary throughout. I am not trying to ignore the hypothalamus. It is absolutely involved. I'm just trying to simplify it. So it absolutely can be a problem with the hypothalamus and not the pituitary, in fact, for all we know after certain brain injuries. And I use different colors and everything too. It's always pinker for the pituitary. But no, hypothalamus also important, but just to focus in on the central messenger, the pituitary. So the pituitary sends out TSH, thyroid stimulating hormone, to the thyroid gland, and thyroid gland makes thyroid hormone. I usually measure that as a free T4, little FT4. The pituitary then reads the levels of thyroid hormone and knows that there's enough there. It's the same way a thermostat in your house works. If it knows if it's too hot or too cold. If the thyroid isn't making enough thyroid hormone, if it's too cold, the signal gets ramped up and your TSH will be high. In an intact system, you can just measure a TSH and know that if it's normal, that the thyroid's fine. That doesn't work if you might have a central, such as a pituitary injury, because the TSH isn't going to be quite high enough to get the right level of thyroid hormone, and you can't mount the proper response. So you can have a normal TSH, but a low active thyroid hormone. And that's one indication of a central thyroid problem. So normal can be misleading. If you look just at the TSH, it's not enough if you might have a pituitary injury.
Your example of the house and like the heating, that would be like a wiring issue between the thermostat and the radiators that produce.
It could be wiring, or in this case, it would be just that the actual thermostat itself isn't reading signals appropriately, or it can't mount the reaction, basically. It can read them, but it can't do anything. It knows that it's too cold, but can't quite get a signal out there to heat up the house. Time of day is also important. All of these hormones exist in a diurnal pattern. They'll be higher at some time of day, lower at other times of day. That can be difficult to think about when to measure in patients, in people who have an altered circadian rhythm and that's disturbed. Admittedly, you don't always know exactly what somebody's rhythm is, but generally speaking, testosterone and cortisol are highest in the morning. So if you're thinking about a deficiency, that's when you need to measure them. Otherwise, if they're low, you don't know if it's a normal low.
And so that if somebody that didn't sleep at night, and you've seen that pattern where people sleep during the day, and then they can't sleep at night. So if a sleep pattern is off, your day may not be the same as what a person who's sleeping at a normal rhythm. So it's really based on your sleep cycle.
You can't, that is true. That is likely to be true. We don't change when we measure things unless somebody has a consistent pattern, like nighttime workers, somebody who always goes to bed at 8 in and gets up at, I don't know, 9 at night, whatever it is. And then you can shift things a bit. But otherwise, if it's just disordered, you don't try to chase after it. You'll still measure at the same time, but you might need to use dynamic tests. So if you can't really trust that you're getting a low level when it should be high because maybe somebody's system is off, the circadian rhythm is off, you can do dynamic testing where you basically try to get the body, you stimulate the body to produce growth hormone or cortisol, and if it can comply.
And these are all blood tests.
They're all blood tests. The provocative tests that I just mentioned are giving something, a provoking agent, and then measuring blood, but they're all blood tests for deficiencies, yes. There are situations where you're looking for excess, where you might use urine or saliva, but for the deficiencies, at the moment, we use, good question. I wanted to stop a little bit and talk about particular considerations in women when I have this illustration of the axis up here. So we mentioned that menstrual irregularities may be an indication of pituitary dysfunction. In adolescence, this can present with delayed puberty, for example. And I have seen cases where people are assumed to be in menopause, but it's actually pituitary hypogonadism masquerading as menopause, is when somebody's periods have stopped for a year. If somebody's having irregular, few, or absent periods, it may be assumed, oh, they're in menopause. So it's easy to tell the difference in this case. In menopause, the ovaries themselves aren't making the same amount of estrogen. The pituitary knows that, and acting like the thermostat, it sends out a higher signal. FSH is elevated, and estrogens are lower than you might expect. But certainly the FSH being elevated is consistent with menopause. If the FSH is low and the estrogens are low, that suggests a pituitary cause. The pituitary is not mounting the response. Now, depending on someone's age, if they were in menopause before, for example, before the injury, it doesn't necessarily mean you would change what management, that you would give estrogens when you weren't before, but it should increase the suspicion for other pituitary problems as well. So I do still measure FSH, age independent, to give that indication. This is a little bit about how you measure the axes. I'm going to skip over this unless there are questions, and I'm happy to go back to it if there are, other than to say that if you have a regular period, if women have regular periods, they don't need that axis measured. Having a regular period is enough of an indication that system is working. You need the other systems tested still if you're having symptoms, but it's enough of an indication that system is working. If somebody's on oral contraceptives or has another hormonal contraceptive or hormones for another reason, you also don't need to measure that system, but it's just because you won't be measuring what the body is making, you'll be measuring what someone's taking off it.
And
I'll mention
by irregular, I'm sorry to interrupt you. It's so fascinating. I'm really trying to,
please.
But a regular period would be a period that disappears, gaps in it, or 2 periods a month, or a much heavier flow, much more pain. Any changes, or would it be one direction or the other?
That is a great question, and I should have been specific. Here, irregular means it's not coming once every X number of days, with that X being relatively the same. Maybe it's every 25 days, maybe it's every 34 days, whatever that is, that it's coming that same interval every month. Coming less frequently, more frequently, or not at all would be irregularity. A difference in flow may be related to a hormone issue, but is rarely due to a hormone deficiency.
Okay, because that when it comes up within the support groups, it's one of those posts that someone will ask about their period, and literally 60 or 70 women within the next hour will go, yes, yes. And they tend to have different reasons for posting and saying that it's irregular. So that, thank you for clarifying that.
Yeah, it doesn't mean there's not something else going on, but a pituitary hormone deficiency leads to usually a less frequent or missing periods. Can be another change in frequency, a change in the nature of the period itself. I'm in no way saying it doesn't bear looking at, but that's less likely to be a pituitary deficiency. Prolactin plays a role also. When prolactin is elevated, it can suppress the sex hormone axis. So if you have an elevated prolactin, that itself can be causing issues sometimes. The other thing I want to highlight, a single blood test is not enough if you're looking for hypogonadism in men. You need 2 or 3 in the presence of symptoms. So just measuring one time, it by guidelines, it's not enough, because again, things go up and down over time. The growth hormone is a little bit trickier here. We used to that measuring IGF-1 was enough. And if it was low, that's when you would go on to do provocative testing. It has become clear now that you can have a normal IGF-1 level and still fail provocative testing. And it is thought that provocative testing is the better test. Okay, I'm using all these terms because we don't really know what the actual answer is, just the best tools we have to describe it. And so you can have a normal IGF-1 and have growth hormone deficiency that would only be found on provocative testing, which I'll talk about.
Yeah,
the other thing that's
this type of testing we're talking about right now, is this something that a general practitioner, the person you have been going to for most of your life for physicals is doing, or have you made a transition, and do you need to see an endocrinologist at this point to do this kind of testing, or a gynecologist? Like who provides this, and where in that care pathway would you get to this point?
Cortisol testing can be done by anybody who knows how to do the testing and is comfortable with how to interpret and immediately react to the test. This one's important because a deficiency in cortisol is the only pituitary hormone deficiency that's potentially fatal if it's not found. Because if you are, heaven forbid, you're in an accident or you get extremely ill and you don't have enough cortisol, you can bottom out your blood pressure, and that's when it can be fatal. It's not that it's fatal in everybody, but it's very much a concern that that be missed. The others will impact quality of life and health, but it won't be this potential emergent situation. So anybody who knows this and knows how to interpret the test can certainly order the test. TSH can be ordered by anybody, again, that if you are suspicious of a central problem, you need to add in a free T4. They just need to know how to interpret it correctly. I sometimes get concerned that TSH is thought to be enough, and it's not. Testosterone, again, anyone who knows how to do it can order the series of morning tests. It's important to think about unbound testosterone in certain situations too. Women, anybody can order if they have irregular or are not on hormones and not having periods for any reasons, it can be, the measurement can be done. If somebody is having periods, but they're not quite regular, you also want to time out, know when in a cycle you're measuring the hormones, because there's different ranges of normal for different times of a cycle. And growth hormone, you can order an IGF-1. The provocative testing, the cosentropin stimulation in cortisol, or the growth hormone provocative testing, those tend to be done only in neuroendocrine offices or in sort of specialty centers.
Do people usually come to you with blood work that we've done one round of blood work, or do people?
Sometimes, rarely.
Okay.
They often have none, or they'll have some testing, or they have testing, but not the types of tests we do to look for deficiencies. All sorts of ranges, because I do see patients from all over essentially. And so they come with any range of, or no results. And if you have results from a year ago, that's not necessarily telling you where you are now. Any set of tests is a snapshot of that time period. Other things can impact the tests. If you were just quite ill, your hormone levels will not be what they normally are. It's not a good time to measure. If you're in the hospital, it's not a good time to measure. This is looking for chronic, consistent problems, and it's best to test. You can't always do this. It's best to test kind of at the relative new baseline. Medications can impact hormone levels, or our testing of them. Biotin, vitamin B7 is in most multivitamins, lots of preparations, doesn't change your hormones, isn't bad for you in that respect, but binds to a lot of our tests. So you can't, it binds to the assays. And so if that's not known, it could be affecting how we measure your hormones. Opiate pain medications can affect hormones. Certainly glucocorticoids or other steroids there's lots of things, or supplements or herbs that can affect hormones. So making sure that who you're seeing is aware of those makes a difference also. You don't want to mask a true deficiency if you're on something that's filling in for it a little bit. The provocative growth hormone piece has thrown a little bit of the wrench of who does the measurements and how. So when it was just an IGF-1 measure, you could essentially do a screen with a single morning blood measurement. Now, if it's all normal, you still don't know about the growth hormone. We are aware now that you don't know about the growth hormone. So you go on to provocative testing. There we go. So go back. So the best test for growth hormone sufficiency, well, I shouldn't say it's not entirely clear. The most available test is not clear. IGF-1 isn't enough, but you can do these provocative tests, and there's a whole host of them. There are several that are recommended in adults, and different ones you tend to do in children, although in children, it's more important to follow their height velocity and their height over time, look at their bone age. In adults, use these provocative solely, really. Insulin can be used, glucagon can be used. There's an oral agent that's on the market that was launched in the summer of 2018. GHRH is the signal from the hypothalamus to the pituitary. That's available in other countries, but not in the US since 2008. So the two most common that you'll probably see are the glucagon stimulation test as a sort of gentler way of doing the insulin tolerance test, and this new massimorelin test, which is oral. The other one's a shot. Each test has its own thresholds, and there are very clear parameters for when you have growth hormone deficiency, but those were not adapted in the same way by the TBI studies. And access to testing is absolutely an issue. You have to be able to see someone who knows about these tests, but you have to be able to get in to do the test. Not everywhere does the growth hormone deficiency tests. And again, major academic medical centers often will do them, or infusion centers, but that's a concern for me. How do you find a place that knows how to do it so someone doesn't have to repeat it? And how do you get the patient to that place? Okay, so clinical implications. Are there questions about testing? I got bogged down in specifics there, but are there questions about pituitary hormones or testing before I talk about why this is relevant in a population after traumatic brain injury?
There are some questions, but I really like you to, let's keep going with your slide decks. I'm going to be quiet, and then we'll go back and read through them, and we'll do like rapid fire, I think.
And I see that I slowed down a little bit, so I'm going to speed up here.
It's so interesting though. I so appreciate it.
I want to have time for questions, and so let me just keep all, yeah. So basically the patient that I mentioned, the person who came in 6 months after an injury, and it looked fine on the initial screen, cortisol, we did a cort stim, that provocative test. You need to get it above 18 on older tests like this was. It was well above that. Both the TSH and the free T4 were normal. Thyroid axis at the time was normal. Testosterone was not low. Prolactin was fine. IGF-1 looked fine, but knowing at that point that's insufficient, we did a provocative test and found he failed the provocative test. The peak value growth hormone did not meet the threshold level for having enough growth hormone. So this gentleman had growth hormone deficiency. And growth hormone, you think about it as being for growth. It does, it helps people attain their adult height. But once they've reached adult height, it has other effects throughout the body. It affects thinking. So changes in cognition, concentration, short-term memory, word finding, that can be related to a growth hormone deficiency. It affects the heart, the cholesterol, glucose metabolism. These are things that somebody may not have symptoms of, but are important, but are effects of the growth hormone. So bones, your bone strength won't be as good as it would be if you don't have enough growth hormone. You won't necessarily notice that, but it can be measured. Joints also. Quality of life is a big indicator in sort of determining whether someone's having effects of growth hormone deficiency, body composition, and exercise capacity. So mental fog and fatigue are really commonly mentioned by these patients. And for that reason, if someone has symptoms and is found to be deficient, it's recommended to replace the growth hormone. I am going to skip over this aspect because I want to leave a little more time than for questions, and just go to a summary to say that I think it's important to think about this, that it's really symptoms that indicate who should be tested. And there's a lot of opportunity for increased awareness, certainly for increased research with consistent use of guidelines defined deficiencies, the more information on why this happens, but on an individual basis, it's really awareness and providing the appropriate testing and guidance that I think is the most important. So I want to pause for questions, and I'm so sorry I spoke for longer than I thought I would.
No, it's fascinating. We will include your slide deck so that those can. We did talk about age being a variable. We talked about what sex organs you were born with. Is there any different that they find in race, ethnic background, a certain group, indigenous people? Is there a group that you would see this more in, or that more vulnerable?
Not that I know of. It has not been described in the literature, and its reference ranges may be different too, but that we only know what has been studied. So there's certainly a lot more room for studying there.
That's awesome. So I appreciate that. So there's some questions in the chat. I'm going to go back to the larger, actually I do want you to share your screen though. So let's look through, oh, you have a lot of, one of the questions was, do you check testosterone in women? The answer was yes on that.
No, I don't check testosterone in women. This is a good question. Testosterone, the ranges, the tests we have were developed for men. They're good if somebody has an elevated testosterone. It can tell you if a woman has an elevated testosterone, but looking in the low levels, the tests we have aren't as good in the low levels, and it's unclear what difference that makes. So there are people who are studying this and who specifically with questions like libido, but that would be far after determining if there are deficiencies in stress hormone, thyroid hormone, estrogen in women, or testosterone in men. I also don't generally, for other reasons, I don't generally look at estrogens in men when you're looking for pituitary deficiencies after concussion, and the growth hormone axis, as well as prolactin. So I don't look at testosterone in women unless I'm concerned it's elevated on a general basis.
Question, does concussion at age 15, could that be a cause of fertility problems in the mid-30s?
That's a great question. If there was a deficiency that was never found or addressed, it could. Other things there's a lot of things that can impact fertility because there are other things that impact the pituitary besides concussion, right? Stress, dietary fat, nutrition, exercise, all these sorts of things can change your pituitary hormones. And if you're able to remove whatever's causing the change, can really help. I want to talk more about that because I've done neuro and reproductive endocrine throughout my career, but it's not specific necessarily to the TBI, but it can be. Again, if there's an issue, if you haven't been having regular periods, yes. If you have an undiagnosed growth hormone deficiency or thyroid deficiency, yes.
I think you're going to have to come back for a third talk. I'm just saying.
Yes, and that would be great. I should have booked longer, and I'm so sorry.
And I know you have to go. What about elevated prolactin level in a woman? Fairly common, that level over after a TBI. Could that just be someone's a higher level?
So prolactin itself isn't bad for you that we know of. The symptoms you can get from an elevated prolactin come either because it causes galactorrhea, which is stimulation of milk production from the nipples, from the breast, which is also not bad for you. There are people who can have it and not bother them, but if it bothers them, it's a reason to treat that. Elevated prolactin above a certain level can also suppress FSH and LH. So you can end up with a low sex hormone state because of the elevated prolactin. I do think, and there's less information about this, that if somebody is having a regular period, if a man is not having sexual side effects, let's leave it in women here. So if a woman's having regular periods and a elevated prolactin, like not just a little elevated, but a bunch elevated, essentially, they're having regular periods, but they're not ovulating, that might be from the elevated prolactin. And you can treat elevated prolactin if you can't remove the cause of it, because it can be caused by medication, stress, pain, all sorts of things. You can treat that with a pill also. It is important to think about in the setting of either suppression of the sex hormone axis, disturbing secretion of milk from the breast, or fertility.
And then to find someone that does what you do and does what you've talked about, is endocrinologist the term to Google, or is it neuroendocrinologist? What does one put into Google to find what you're talking about?
It's a good question, and I have an unsatisfying answer. So you can look up endocrinologists because some endocrinologists are aware of this. Some physiatrists are aware of this. Some neurologists are. It's the awareness that makes the difference. It is likely to be enriched for in a neuroendocrinologist who studies the pituitary. So neuroendocrine is a subset of endocrinology and focuses on pituitary-related hormone axes. But again, it really depends on someone who's aware of this. There are lists, I think, that are kept by certain advocacy groups. I often hear from people, and I'll sort of recommend those I know in different states if I know someone. It was for that reason, actually, that I started when I was able to add licenses during the pandemic, seeing people in other states, because not everybody has access to someone who is aware of this. And I know that it takes a lot to go through how you're feeling and what's happened and try to make yourself heard. And to do that again for someone who might not hear you is a cost, really. So I know it's hard to find the right person. It doesn't have to be an endocrinologist. It does have to be somebody who's aware of this and knows how to test for it.
It is 2:55, and I had promised to get you off the call on for your next appointment. Thank you for slotting us in your really busy day and coming back. And I just find this fascinating and really appreciate the time that you've spent. Is there anything that you would like to leave the audience with?
Yeah. So first of all, thank you so much. It is my fault for focusing on my slides when I really love focusing on questions. So I would love to come back and answer more questions. I have a patient at 3, so that's the only reason that I am having to jump off. But I think this is really important, and it's my favorite thing to do is to answer questions about it. I noticed one question that came up about if you had growth hormone deficiency and were treated for it when you were younger, over 18, you need to look at it again. The recommendation is to get tested again. It depends on the reason for it. for having the growth hormone deficiency. So you may not have as an adult, but I do think it's important to think about. And that would be, again, depending on the reason somebody was needed to be treated with growth hormone as a child, it's worth testing as an adult, absolutely, because it does get missed. The growth hormone is often thought of as for growth, and it's not just for growth.
So real quick little teaser, are you having people with long COVID come in with some of these issues?
I am, and I am so interested in this. I'm studying it, I'm testing them, I'm studying it with a few groups, because one of the potential reasons thought to be behind pituitary dysfunction after traumatic brain injury is the setting up of a chronic neuroinflammatory state. I think that some of long hauler syndromes are from neuroinflammation, the neuro-COVID, not shortness of breath, but mental fog, brain fog, fatigue. So I'm extremely interested in that and actively studying it, and would love to talk about that more as I get more information. Certainly seeing patients with it. Thank you.
Thank you so much. I so appreciate your time, and we will have you back again. Thank you everybody for coming to the session, and we will see you next week, same time. I think we're booked out now through April. So keep us on your schedule. And if you sign up once, you will get invitations to every week. Thank you so much, Dr. Wexler. And I do appreciate your time and donating, your time to educate everyone. It's such important work. Thank you.
I really, listen, I'm going to beg you for more to get to answer more questions. And we can focus on that next time if you'll have me.
No, and this is the basics that we didn't get to talk about last time. So I think it all comes together. So thank you so much. Everyone, take care, and we'll see you all next week. Bye-bye.